Off you go, Helen.
Lovely. Hi, everyone. Great to see you all today and welcome you to the collaborative webinar series from Rural Health West, ACRA WA, WACS, the Rheumatic Heart Disease Registry, and Heart Support Australia. So I'd like to start by acknowledging the Whadjuk Noongar people on whose land I am today, and I acknowledge the custodians of the land and acknowledge the effects of colonisation and that we all must take steps towards healing. I recognise the importance of self-determination and that we must stand beside Aboriginal people to restore pride in the past and present so we can together inform the future. I also acknowledge Aboriginal people within the room for their courage, resilience, and their gentle spirits. So today I have with me Professor Andrew Maiorana, and Andrew is going to speak about exercise in the management of patients with heart failure. Andrew has a vast career in this and experience in this area. Andrew is the head of the Department of Exercise Physiology at Fiona Stanley Hospital and Professor of Clinical Exercise Physiology at Curtin School of Allied Health at Curtin University, and is a clinical researcher with over 30 years of experience in cardiac rehab and in heart failure. And it's always my pleasure to introduce Andrew. It feels like more than 30 years, but please take it away, Andrew. Thank you.
Thanks so much, Helen, and thank you for that really lovely welcome to or acknowledgement of country. Yeah, 30 years, it makes me feel old, but I've been around for a while. So I'll share with you a little bit about the work that I've done over the past 30 years or so, and also provide a bit of context to exercise training in heart failure. I'm happy for people to ask questions as I go. So you can either pop a question into the chat or you can raise your hand, and then I can maybe get you to ask the question verbally and address the question. I think it always makes it a little bit easier just to address some topics that people are not sure about as they come up. So please feel free to ask questions as we go. Otherwise, we can have a bit of a yarn at the end of the session as well. So Helen's given a very kind introduction. I've been working in heart failure management since the mid-90s, working with the Advanced Heart Failure and Cardiac Transplant Service, formerly at Royal Perth Hospital, but now at Fiona Stanley Hospital. But I also work as a research academic at Curtin University. So just by way of a quick overview of some of the topics that I'll discuss today, I'm going to do a bit of an introduction to heart failure, and I do apologise if if this is sort of giving you information that you're already aware of, but I suspect it's a fairly diverse audience, so it's often helpful just to set the scene with a bit of information about what heart failure is and how it impacts on the body's ability to exercise. It's a really horrible term. I think it's a term we probably need to move away from. Yeah, a lot of people who are given a diagnosis of heart failure are really confronted by that description. And I know, there are patients that come to the Advanced Heart Failure Service at Fiona Stanley Hospital where I work, and there's a big sign above the door saying Heart Failure Service. And some people have never heard the term before, and they turn up for an appointment and they sort of go, oh, am I in the right place for heart failure? So it's a confronting term, and probably one that we need to think about changing, I believe. I'll talk about exercise physiology in heart failure. So this is really about the physiological and pathophysiological response to the syndrome of heart failure and how it has an impact on the person's ability to exercise. Provide a little bit of evidence around the benefits of exercise training for heart failure, and just touch on some of the historical context, because for a long time exercise was seen as a contraindication to people with heart failure. And it wasn't until relatively recent times that people with heart failure were included in cardiac rehab and exercise training programs. Now I'll finish off with just some practical applications of exercise training. So as I said, heart failure is a term that's pretty confronting for lots of people. It simply means that that the heart isn't pumping as strongly as it should. And historically, heart failure has been defined by a reduction in ejection fraction, so a reduction in the pumping capacity of the heart. However, over the last 10 to 15 years, it's been increasingly recognised that some people have a problem with their heart that's not so much about the ability of the heart to contract, but it's more related to the fact that the heart becomes really stiff and it can't fill up with blood. And when we're talking about the heart, we're talking about predominantly the left ventricle of the heart. Heart failure can affect both left and right ventricles, but the left ventricle of the heart, being the ventricle that pumps blood around the body, is the one that's most often affected, and it has the most significant effect on a person's ability to exercise. So now we characterise heart failure both as heart failure with reduced ejection fraction. So that's a situation where the heart can't pump enough blood out of the body because it doesn't have that ability to contract, or heart failure with preserved ejection fraction, where the heart becomes a bit stiff and it doesn't relax during diastole and fill up with blood. So because it's not filling up properly, when it contracts, it doesn't eject as much blood as it needs to. So the effect of both heart failure with reduced ejection fraction and preserved ejection fraction is that the cardiac output is compromised. So there's less blood leaving the body per minute, less blood leaving the heart per minute, and less blood leaving the heart with every heartbeat. Okay, so there are just a couple of echo images here. The first one that I'll show you is of a normal heart. So you can see that the walls of the left ventricle are relatively thick and muscular. The lumen of the left ventricle is not particularly great. Maybe it's 5 or 6 centimeters diameter, compared to a person with dilated cardiomyopathy that has very thin walls of the left ventricle, and really a heart that's not contracting much at all. So let's look at the normal heart to start off with. So this is an echocardiographic image. Sort of the top of the image is the bottom of the heart. So the probe taking the echo is coming from under the ribs. And you can see that the heart is, the walls of the left ventricle are relatively muscular, and it's contracting with a lot of vigor. In contrast, a heart with a dilated cardiomyopathy, so left ventricular dysfunction and a reduced ejection fraction, it's a big, baggy left ventricle, thin walls, really not contracting with any great vigor, really just sort of wobbling around, and not ejecting much blood from the body and from the heart and out around the body. So heart failure with reduced ejection fraction, or HFrEF, is when an ejection fraction measured on echocardiography, so this is the amount of blood or the proportion of blood that's being ejected with each heartbeat, is less than 40%. In terms of preserved ejection fraction, it's when the ejection fraction is greater than 50%. So normal ejection fraction is around about 60 to 65%, maybe up to 70%. The heart doesn't eject all of the blood with each heartbeat, but when it's less than 50%, it's considered abnormal. And there's this sort of mid-range level of reduced ejection fraction that we call mildly reduced ejection fraction, with an ejection fraction of less than between 40 and 50%. Okay, so in terms of the functional impact of HFrEF versus HFpEF, there are a number of different sort of pathophysiological responses. So HFpEF, remember, this is where the problem of heart failure is caused by a stiff heart. It's typically related to the diastolic phase of the heart, when the heart's relaxing and filling up with blood, or supposed to relax and fill up with blood. But ejection fraction is relatively well preserved. The problem is that the heart muscle becomes very stiff, it fails to fill up with blood properly, and as a result of that, it doesn't eject as much blood with each heartbeat as it should. HFrEF is caused by systolic dysfunction. The ejection fraction is less than 40%. The muscles of the muscle of the left side of the heart can't contract properly and eject blood out of the heart. So the amount of blood that's being circulated is insufficient to meet the metabolic demands of the body. And that becomes more of an issue when someone's exercising and requiring more blood flow. So it's a problem of left ventricular systolic dysfunction. So the symptoms of heart failure are quite varied. And we see both signs and symptoms of heart failure. One of the signs that we would be looking out for in patients with heart failure is a rapid change in their body weight, because patients with heart failure are prone to fluid retention, and they can retain quite extraordinary amounts of fluid over a relatively short period of time. So whenever anyone comes into our gym, we will weigh them. If their body weight's gone up at least a couple of kilos over 48 hours or so, well, then that would be an indication to us that they're retaining fluid, and it's something that we would need to look into before they start exercising. But we've seen some patients who maybe have been undiagnosed or not managing their fluid balance correctly, who've just gained crazy amounts of weight. I mean, cases where patients have got 20 or 30 litres of extra fluid on board, so they're just completely waterlogged. They've got peripheral edema, pulmonary edema, and as you can imagine, their exercise capacity is really quite poor. Cases where people have literally let it go to a point where they can't walk across their lounge room, and then eventually sort of called an ambulance to come and pick them up. It's quite astounding that people will leave it to that degree. Weight gain reflecting fluid retention is one of the signs of heart failure. Some of the symptoms are that people become quite fatigued. They often have episodes of dizziness and lightheadedness, partially because their cardiac output is compromised, and that can lead to a lowering of their blood pressure. But then on top of that, they're prescribed medications which also lower their blood pressure. And the idea is to try to run the blood pressure as low as possible to take the load off the heart. But it can be a really fine line for some people who are sort of getting benefits from a low blood pressure, but really at a threshold for symptoms if their blood pressure drops just a little bit. So, I mean, in our patient cohort, it's common to see patients with systolic blood pressures of 80 to 90 millimeters of mercury and less than that. And if someone was to walk into an emergency department with a systolic blood pressure of 80 systolic, then they'd call a code blue and people would come running from all directions. But this is the norm for a lot of people with heart failure. Also, in line with the fluid retention, swelling in the ankles is often a really easy sign to identify the impact of fluid retention. Some people will experience irregularities in their heartbeat. They'll be at increased risk of problems like atrial fibrillation, but also more sinister ventricular arrhythmias. They'll have shortness of breath. They may have trouble breathing when they're lying down. And these are all symptoms that some people will experience. Some people will have multiple symptoms. Other people will have just one of these symptoms. And some people can have quite significant impairment of their cardiac function, but relatively mild symptoms. The common causes of heart failure, a heart attack is the most common cause. So at least 50% of people with heart failure have heart failure because they've had a big myocardial infarction and it's wiped out a heap of myocardial tissue, and as a result of that, the heart's not pumping as well as it should. Other common causes are type 2 diabetes, high blood pressure, arrhythmias, and some people can just have blockages in their coronary arteries that's having an impact on their cardiac function, but they haven't actually had a heart attack. Then there are a whole heap of less common causes of heart failure. We see patients with inflammatory problems, valve problems, congenital heart conditions. We now have an adult congenital heart clinic at Fiona Stanley Hospital. Obesity, some cancer treatments, we're seeing increasing numbers of patients that have had chemo at some point in the past, and the chemo has damaged their heart, and ultimately it's led to heart failure. And then other drugs as well. And unfortunately, we see quite a few young people with a history of methamphetamine use who have developed heart failure as a result of that. So the natural history of heart failure is that it's usually precipitated by an index event, and that can be a myocardial infarction. And then people are stabilised, so sort of moving from one where the index event occurs to two where the person's stabilised. And they often have a period of time where their heart failure is relatively well controlled. And then over time, they'll start experiencing episodes of decompensation where their symptoms might get worse. They might experience more fluid retention. They might get admitted to hospital because of this. And the episodes of decompensation will start to gradually increase as someone gets toward more advanced or end-stage heart failure. I think it's important to, just to highlight before I move on to more of a focus on exercise, that the best approach to managing heart failure really is with a multidisciplinary approach. Heart failure is a really complex condition. A lot of people have comorbidities that that they need to manage as well as their heart failure, and the best way to do this is with a multidisciplinary team of medical, nursing, and allied health professionals, so that medical, behavioural, as well as functional approaches to dealing with the person's condition can be addressed. And over the past 20 to 30 years, exercise has really become an important and integral part of the management of patients with heart failure. So I'm just going to talk a little bit about exercise physiology just briefly. So exercise physiology is a biological science that explores the physiological processes involved in both the acute response to exercise and the chronic response to exercise with respect to exercise training. So how exercise training can cause adaptations in the physiology of the body over time. And it can be applied in both healthy individuals and people with pathological states. And when we apply exercise physiology in a pathological state, it sort of helps us to understand what the limitations are to the person who's experiencing a given condition. So in terms of heart failure, as I mentioned before, it's a condition where cardiac function is insufficient to meet the metabolic demands of everyday life. It usually starts with an index event, and then it is a progressive condition. So over the course of time, people tend to get worsening symptoms, and their heart failure follows the natural history, will get worse over time as well. The objective of modern medical therapy is to either slow or halt that progression of heart failure over the course of time. And we often hear that that heart failure, the prognosis of patients with heart failure is worse than with most solid organ cancers. And this is something, you Google heart failure and prognosis, and this is something that'll come up straight away. And a lot of patients see this prognostic information and get really concerned about it, understandably so. I think it's important to note that for many people, they're diagnosed with heart failure in their older years of their life. So, often when someone is diagnosed, their life expectancy is relatively short because they might be in their late 70s or early 80s or even 90s. And that does skew that data. So, the outlook for younger people with heart failure is not as dire as some of the information online will lead you to believe. And it can be quite variable for different people. Some people can have a really rapidly progressive heart failure pathology, and their heart can get worse quite quickly without, or even in the presence of best practice medicine. And those people may need to be considered for advanced medical therapies like cardiac transplantation or left ventricular device implantation. But for lots of people, just with standard medical regimens and exercise, can really live a long and productive and relatively healthy life, despite the fact that their heart's not pumping as well as it should. So we need to reinforce this with people, and just make sure that that they do have a positive outlook for the future, and highlight that there are lots of things that they can do in terms of their self-management that will improve their outlook, and exercise is part of that. I am digressing somewhat, so I'll get back to the script here. And I think it's just to mention again, and this is really just setting the scene for why we exercise people, to mention a self-perpetuating cycle in heart failure. So it does start with this initial myocardial insult, which has an impact on myocardial contractility, reduces the circulation of oxygenated blood around the body. But because there's less oxygenated blood getting pumped out to the periphery and out to the skeletal muscles start to change. They start to become more reliant on anaerobic metabolism and less reliant on aerobic metabolism, which means that they fatigue more quickly. People then get more physically deconditioned because they're experiencing early fatigue, and then ultimately get into a bit of a downward spiral in terms of their exercise capacity. So what we're trying to do with exercise prescription is really break this cycle, get people being active, exercising, stimulating the body to send more blood to the muscles because they're demanding it as a result of the fact that they're exercising, and then ultimately lead to adaptations that improves a person's fitness over time. So sorry, is that a question?
Oh, there is a question it can wait till the end, but it might be relevant for people's learning as you speak. It's the particular causes or factors that make someone more likely to have heart failure with preserved ejection fraction.
Okay, I can answer that quickly now. So certainly older age, we know that both preserved and reduced ejection fraction heart failure increases as people get older, but certainly heart failure with preserved ejection fraction is far more a condition of people who are older. It's also more likely in people with a history of hypertension and type 2 diabetes. They seem to, be precipitants for heart failure with preserved ejection fraction. And it's much more common in women than in men as well. The challenge with heart failure with preserved ejection fraction is that there are relatively few effective medications. Possibly the only one or the only class of medications that have been shown in big clinical trials to be positive, and this is only in the last few years, SGLT2 inhibitors. So it means that there's not a lot that can be done to reduce the progression and the clinical effects of heart failure with preserved ejection fraction. Some people will benefit from some diuretics because people will often still have fluid retention problems, but otherwise there's not a lot of effective medical therapy. And I think it makes the case even more strongly for the importance of exercise for this group. It is worth mentioning because these people are often older. They often have more comorbidities as well, so it can be more challenging to prescribe exercise. But yeah, exercise is also really important for these people.
Thanks.
Okay, so I'm just going to introduce the concept of cardiopulmonary exercise testing. We use this quite extensively at Fiona Stanley Hospital in evaluating a patient for prognosis and using it to guide exercise. But it's something that's not widely available, and it doesn't, it's not an absolute requirement for prescribing exercise. What I really want to do is just highlight cardiopulmonary exercise testing as a way of introducing VO2 peak. So VO2 peak is really the gold standard for measuring aerobic fitness. And it's a function of both oxygen transport capacity and oxygen utilization at the skeletal muscle level. So it depends on both cardiac output, and cardiac output is obviously limited in someone with heart failure, but also the difference in arterial and mixed venous oxygen. So this is about the muscle's ability to extract oxygen from the body, or from the bloodstream. And we can measure it by doing a cardiopulmonary exercise test and collecting the expired air and analysing the expired air, which allows us to measure concentrations of oxygen and carbon dioxide as people breathe it out. But what is it's showing us indirectly is what's happening in the mitochondria of the muscle in terms of oxygen exchange and the utilisation of oxygen to fuel aerobic metabolism. Now, in patients with heart failure, there's a bit of both a reduction in cardiac output going on, but also as a result of that, over time, the skeletal muscles, as I highlighted before, become less aerobic in their capacity. And when we're prescribing exercise for people, we're not really targeting an improvement in cardiac output. The change in cardiac function with exercise training is relatively limited. There's some evidence to suggest that it might occur to some degree, but maybe only a 5% improvement. In terms of aerobic fitness, we see up to a 20 or 25% improvement over time. And really the difference is the fact that the skeletal muscles are working more effectively and efficiently and able to extract more of the oxygen out of the blood that's being pumped around. And that's really where the money is in terms of prescribing exercise. So we should be targeting the periphery as much as we can. To put VO2 peak into context, so one way of describing the functional ability of people with heart failure is to use the New York Heart Association functional class. So what I've just done on this slide is use functional class and then VO2 peak as a way of describing the level of aerobic capacity that someone with heart failure of different functional classes might have. Just to put things into perspective, the VO2 peak of a healthy man of, say, 50 years of age would be around about 35. For a woman, it's probably a little bit less than that, maybe around about 28 to 30. So, even someone with relatively mild heart failure will usually have a VO2 peak of well less than 30. So class 1, they'll have a VO2 peak of above 20 mils per kilogram a minute. That's measuring the amount of oxygen that they're able to use at the peak of their exercise capacity. Class 2 heart failure, people with moderate activity causes symptoms, would typically have a VO2 peak of 16 to 20 mils per kilogram a minute. And then it's class 3 and then class 4 are the people that have really quite significant symptoms from their heart failure. So class 3, minimal activity causes symptoms that have a VO2 peak of 10 to 16 mils per kilogram a minute. And then person with class 4 heart failure is someone who'd be getting some symptoms at rest, and they would have a VO2 peak of less than 10 mils per kilogram a minute. Resting metabolic rates around 3.5 to 4 mils per kilogram a minute. So it's really, these people with class 4 symptoms really only need to walk 20 or 30 metres and they're completely exhausted. So it's class 3 and 4 patients that we might consider for listing for cardiac transplantation. And we know that in someone who has a reduced aerobic capacity, as measured by VO2 peak, they have a much worse prognosis over time. And this is just data from our lab at Royal Perth, actually, going back a few years. It's a Kaplan-Meier chart, so it tracks survival over time. The blue line is the patients who had a VO2 peak of greater than 14. The red is a VO2 peak of less than 14. So you can see that there's quite a discrepancy here in terms of survival. The people who have the lower level of fitness and are characterised by the red line here, their survival over time is much worse, so much so that at 5 years, their survival is about 55%. Compared to closer to 80% for those with a higher level of aerobic fitness. And part of what we want to do with exercise training is try to increase VO2 peak. And we know that if we can increase VO2 peak, it will reduce the prognostic implications of someone's heart failure. So just moving on now to exercise training and heart failure. We have an outpatient program that we run at Fiona Stanley Hospital. For patients with heart failure, we run it 3 days a week. We're fortunate that we've got a fully equipped gymnasium, and the program's run by both exercise physiologists and physiotherapists. So patients will come in 1 to 3 times a week. We'll encourage people to come in 2 to 3 times a week if they can. They'll come for sessions that last for an hour and a half, but they'll probably be exercising for about an hour during that period, starting off with a low level of exercise and then gradually increasing their exercise as their fitness starts to improve. So exercise training hasn't always been something that's been part of the management of patients with heart failure. Before 1980, it was actually contraindicated for patients with heart failure. And it really wasn't until really the mid to late 80s that patients with heart failure were starting to find their way into cardiac rehab programs. There are a couple of trials that were published in the late 1980s of exercise training in heart failure that found that patients with heart failure seem to actually tolerate exercise reasonably well. And importantly, they showed improvements in measures like VO2 peak as a result of an exercise training program. What was identified at this point, and is something that has been evident in the literature really ever since, again, is that when we exercise train people, the heart doesn't get a lot better. It's really the periphery where the adaptations occur that improve a person's fitness and reduce their symptoms. So really by the early 2000s, there'd been a complete turnaround in opinion regarding exercise. So this is a statement from the Heart Foundation. When medically stable, all heart failure patients should be considered for referral to an exercise program. And that's pretty consistent with our philosophy at Fiona Stanley Hospital. It's very rare that we have a patient who we can't get into the gym and do some degree of exercise, even if it's relatively low intensity. I can really only think of one or two patients, certainly over the last 10 years, who have just been so clinically unstable over an extended period of time that we've really struggled to get them into the gym. Often they need to be stabilised, and it might take a week or even 2 weeks before the clinicians get to that point with the patient. But invariably, we can get them into the gym over a period of time. So exercise training has been shown to be both safe and effective for improving functional status. Okay, and this is a class 1 recommendation with a level of evidence at A, which is the strongest level of evidence. It reduces hospitalizations, improves quality of life. And then there are a number of studies which have shown that it reduces all-cause mortality, especially in patients that have indicators for poor prognosis, such as lower fitness, lower ejection fraction, higher BNP levels. In terms of the exercise prescription that we would undertake for people, we always have a combination of aerobic and resistance exercise. In terms of the intensity of aerobic exercise, we typically start quite conservatively and build the duration of exercise that a person's undertaking before we increase the intensity. So starting at 40 to 50% of their peak exercise capacity, and we can base this on their VO2 peak or their heart rate reserve from an exercise test, or just be guided by a rating of perceived exertion of 11, which is considered fairly light, to 13, which is somewhat hard. In recent years, there's also been a lot of attention on high intensity interval training for patients with heart failure. And we do use high intensity intervals of exercise in some of our patients, but we're quite selective with who progresses to that level of intensity. We would always advocate that that people should go through a period of moderate intensity exercise before they're considered for high intensity interval training. And for some people, it's just simply not a suitable mode of exercise. Whereas others, especially some relatively young patients who've had quite a good exercise history and perhaps have had a viral cardiomyopathy that's affected their heart, really over a short period of time, sometimes we can get to quite significant intensities of exercise with those individuals. So resistance exercise is really important as well. Again, starting at about 50% of a 1 repetition maximum, and aiming to prescribe exercise at 12 to 15 reps to moderate fatigue initially, and then starting to increase the workload over time so that we're getting to about 8 to 10 reps where that brings on at least moderate fatigue. But it's really important that they maintain a good technique through their exercise. Probably the most widely used tests of functional capacity in cardiac rehab setting is a 6-minute walk test. And we can use the 6-minute walk test to guide exercise prescription as well. So for people who perform a 6-minute walk test and we can calculate the distance that they've walked, then we can use from that, or we can calculate from that their average walking speed and then use that to guide exercise prescription. So if someone has a rating of perceived exertion of 11 or less, so they rate their 6-minute walk test as being fairly light, then it's reasonable to start prescribing their exercise with walking, for instance, at about 100% of their walking speed during the 6-minute walk test. And we'd normally prescribe that for about 10 minutes in the first instance. If their rating of perceived exertion is sort of 12 to 14, around that somewhat hard mark, then we prescribe the exercise at 90% of the walking speed during a 6-minute walk test. And then if their rating of perceived exertion is hard over the course of a 6-minute walk test, then we prescribe the exercise at about 80% or even less of their 6-minute walk test. So it's quite an easy calculation to do, as you can see on the screen at the moment.
Andrew, can I take you back a step just to Chantel's question around being medically stable? Would you have to be stable for a certain time frame before? So could you?
Yeah, it's a good question. Look, it depends a bit on the setting where the exercise is taking place. I would, if it was a community setting, I would suggest the person should be medically stable for 1 to 2 weeks at least. In a tertiary hospital setting, it's not uncommon for the cardiologist to be quite proactive in referring their patients for exercise. So there are times when a patient might still be an inpatient. They've probably been medically stable for 72 hours, and then they might be referred to the gym for gentle exercise at a low intensity. So I think it varies a bit on the setting. Within a hospital setting like the one that we have at Fiona Stanley Hospital, if we're concerned about a patient after they've been referred to us, then we can liaise back with the referring doctor, and that can be addressed. Whereas it's not quite so easy to do that in a community setting. So I'd suggest probably 1 to 2 weeks, erring toward 2 weeks for people in a community setting where you don't have that same level of medical support.
Thanks.
Just in terms of resistance exercise, so we always start with a low intensity load because the focus initially is just really making sure that people get their technique right. And so a lot of people that we deal with have never really worked out with weights before. So relatively low intensity weights, getting the technique right initially, and then progressing quite quickly to slightly heavier weights. Otherwise, you're really not getting a lot, or the patient's really not getting a lot of benefit from the exercises that they're doing. We normally do a 1 repetition maximum test after about 4 weeks of sort of introductory exercise. And then that can just help us tailor the exercise prescription for resistance exercises a little bit more. I'm just going to move a little bit more quickly through my slides because I'm mindful that we're going through time. As I mentioned, we get people to come in to the gym 2 or 3 times a week if we can, but we also encourage them to exercise at home so that they're developing some independence with their exercise. This is just one of the studies that we've done, which was a combination of aerobic and resistance exercise, but actually prescribed in a circuit weight training format, so that people were alternating between resistance stations and cycling stations on the bike. And what we found with this approach was that both strength and aerobic capacity as measured by peak VO2 was improved. And it was a really time-efficient way of improving both of those outcomes. We also looked at how the exercise training affected vascular function and the ability of the arteries to vasodilate and allow more blood to flow through. And we found that exercise improved vasodilator function over time. So high intensity interval training, or HIIT training, has probably been the most controversial topic in patients with heart failure. But the latest guidelines are advocating that, at least in some patients, they should be considered for high intensity interval training. So this sort of pictorial representation of exercise intensity in high intensity interval training is on the left. So you can see that there are sort of, with the most common approach, there are these 4-minute intervals of higher intensity exercise interspersed with 3-minute lower intensity intervals where people get a bit of recovery. This is the most common approach that's being used in patients with heart failure. And we used it in a trial in patients with left ventricular assist devices. So these are people with really severe heart failure who are fitted out with a little pump that goes into the left ventricle to help circulate blood around the body. And they come into our gym usually in the lead up to moving to the next step, which is a heart transplant. And then we did a randomized controlled trial of high intensity interval training in this cohort, who historically have been really sick with their heart, but because they've got the heart pump, they become much more stable and their exercise capacity improves quite significantly. So on the left-hand side there is just a picture of a left ventricular assist device with a cannula in the left ventricle going to a little pump, and then another cannula coming back to the aorta. So the pump doesn't replace the left ventricle, it supports the left ventricle. But the majority of blood will be travelling through that pump and into the aorta and circulated around the body that way. But what we found was that the high intensity interval training approach improved VO2 peak more than with a more moderate intensity continuous form of exercise. So the moderate intensity group had a 1 mil per kilogram a minute increase in their VO2 peak compared to a 3 mil per kilogram a minute increase over time. And so the rationale is that you're exercising people at a higher intensity, putting more training load on the muscles, but you're just doing it for relatively short periods so that people get the benefit, but they don't get exhausted from the high intensity exercise because they're backing off for 3 minutes every 4 minutes or so. Okay, we talked a little bit about clinical stability and exercise. So I just wanted to highlight some of the absolute contraindications to exercise. Certainly unstable angina, if someone's got symptoms of angina at rest, or their angina's been getting worse, then that needs to be addressed. They shouldn't be exercising. Really high blood pressure is a problem. An orthostatic fall in blood pressure. We shouldn't exercise people because there is a risk that you'll get more of a fall post-exercise. And then that can lead to people feeling dizzy, lightheaded, or even passing out. If they've got really bad symptomatic aortic stenosis, we wouldn't exercise them. If someone's generally unwell, they shouldn't be exercising. So, these days we typically don't want people sort of coming into an exercise environment if they do have some illness. But they shouldn't be exercising. It's really a time that they need to rest and recover and get themselves back to their normal level of health before recommencing exercise. Any uncontrolled atrial or ventricular arrhythmias, then people shouldn't be exercising. And if they've got decompensated congestive heart failure. So that's when they're retaining fluid, their symptoms are getting worse because they're getting more short of breath. That needs to be sorted out before they can start or recommence an exercise program. So just some general guidelines in terms of keeping everyone as safe as they should be. It's about knowing your patient's clinical medical history, and if you're not sure, you need to find out, and that might be liaising with their GP or cardiologist. We have the luxury of having medical records at Fiona Stanley Hospital, but that's not always the case if you're working in an environment outside a hospital. I always say, look, listen and feel. Look at how the patient presents to you. People who are unwell often look unwell. Listen to what they're telling you about how they're feeling. You can also listen to heart sounds and feel, you take their pulse, take their blood pressure, have a conversation with them about how they're feeling. So we check blood pressure, heart rate and weight before every session. We review people for signs of worsening heart failure by looking at their ankles and making sure that their ankles aren't becoming swollen, that they haven't got an elevated JVP. They're not visibly looking like they're struggling for breath. So pitting edema in the lower legs is one of the things we look for. And as I mentioned, elevated jugular venous pressure and dyspnea. Okay, so we do need to think outside the square a little bit just to improve access for exercise. Not everyone has access to an outpatient cardiac rehab program, and not everyone wants to come to an outpatient cardiac rehab program. So we do need to think, how we can support different groups within the community. So there's been some really successful cardiac rehab programs running cultural centres for different ethnic groups, using translators for patients in whom English is a second language, age-appropriate programs for younger patients. So we have adult congenital heart disease patients who come into some of our sessions, but they're usually sort of 20 to 40 years of age, so often a lot younger than the heart failure cohorts that we see. And we've run some really successful exercise programs for both heart failure and general cardiology and Aboriginal medical services, both here and in some regional centres as well. There are various emerging strategies supporting exercise in patients with heart failure: wearables, tele-rehab and remote monitoring, aquatic exercise, exergaming. This is an example of the exercise sessions we used to do with one of our youngest patients. You can see she's got a little bag over her shoulder. So she had one of these heart pumps called a left ventricular assist device. Unfortunately, she had been diagnosed with cancer when she was really young. The chemo had damaged her heart, and ultimately she needed a heart transplant. She came to us as a 9-year-old to get exercise rehab. And the good news is I think she's 17 now and a really striking young lady, loves dancing, and has just done so well. But just to give you a little example of the activities that we do with her using a Wii Fit. So one of our exercise physiologists and one of the cardiologists helping out there as well. So I'll just go through another couple of minutes and then I'll wind up. So prior to any exercise sessions, we check patients out and we check them out again before they leave. Any of the red flags that we might be on the lookout for are changes in their heart rate or rhythm, changes in their blood pressure, especially low blood pressure is what we typically see more in patients with heart failure. And if their blood pressure is less than 90 systolic and they're experiencing symptoms, we wouldn't exercise them and we'd follow up accordingly. And as I mentioned before, changes in weight of at least 2 kilograms over 48 hours. And if they're gradually having a reduction in their exercise tolerance over time, then we would also consider why that might be the case and whether we need to support the patient in seeking some further medical follow-up. So just to move quickly through some slides about initiating exercise. So the general principles are start slowly, progress gradually, increase duration before intensity. Have rest days as required for people, especially early on in a program. There really is some value in supervision initially, especially for resistance exercise, just to help guide people in their exercise program and teach some good exercise techniques. But then, moving to a system of both supervised and unsupervised sessions so that people develop some independence around the exercise that they're doing. It's important to incorporate activity into daily life. Encourage people to consider activity as an opportunity, not a burden, not avoiding activity at all costs. Encourage people to undertake domestic duties. Too often we see that a well-meaning spouse will, stop the patient in the family from doing anything physical and do everything for them. But that's really, quite and has a negative impact on a person's physical fitness, but also their sense of self-worth. So we encourage people to maintain those domestic duties, not sit around for too long, break up prolonged periods of inactivity. Even if they're not feeling great, just get up and walk around the house a little bit. Don't sit down in the lounge or lie down in bed for extended periods of time if you can help it. It's quite useful to track steps every day just to give people some feedback. And that can be done simply with a pedometer. And then ultimately trying to achieve those guidelines for good health of at least 30 minutes of exercise on most days. People will have good days and bad days, so they may need to modulate their exercise a little bit accordingly. Often when they're started on a new medication or their medication is increased, they'll feel worse before they feel better. And sometimes they may need to down titrate their exercise following up titration of medication. And they need to manage their exercise and expectations accordingly. So it's important to have ongoing surveillance of symptoms. Don't start or actually cease exercise in the event that people do experience any chest pain or discomfort or abdominal pain. And sometimes people with heart failure will present with abdominal pain on exercise because they're just simply not able to supply enough blood flow to their digestive system during exercise because it's being prioritised elsewhere. Dizziness or lightheadedness, they should stop exercising and be reviewed. Any onset of palpitations or heart rhythm abnormalities, and difficulty breathing beyond what they might normally experience as their shortness of breath, as well as severe fatigue. It's important to keep environmental conditions in mind, both extremes of heat and cold, put additional load on people. Avoid exercise during extremes of temperature and humidity. Obviously, this is common sense, but it can be really challenging for some people, especially people who live in the north of the state and have extended periods of time where it's really, really hot outside. Looking for an air-conditioned environment where they can do some exercise, even if it's just going to a shopping area and walking around in there. Maintain appropriate fluid balance. It can get a little bit more challenging when it's hot and humid. Avoid exercise in poor air quality as well. If there is pollution around, that will have an impact on a person's exercise tolerance. So just to summarise, and I do apologise for rushing through those last couple of slides, but exercise training is safe for the vast majority of people with heart failure. And we've exercised thousands of the sickest of the sick heart failure patients over the past 20 to 30 years, almost 30 years now. And I always touch wood when I say this, but we've never had a patient die during one of our exercise sessions. So if exercise is appropriately prescribed, it really is very safe for people with heart failure, and they get much more benefit than any very small risk there might be of them having an adverse event. it improves their quality of life and their functional capacity, and ultimately it can lead to improved clinical outcomes. And what we should all be doing as health professionals is exploring ways of delivering exercise to people, that suit their situation and suit their needs. And I acknowledge that can be, potentially quite challenging in regional and more remote locations. So thank you very much for your attention. I think we've gone pretty much the full hour here. I am happy to answer any questions that people may have.
Your timing was perfect. Thank you, Andrew. A great mix of evidence and a common sense approach. There is a question around, David, the recordings are shared, but Andrew, would you be happy to share your slides?
Yeah, yes, of course. Very happy to. And happy for, you can see my email there on the screen. Very happy for people to reach out if you do have a question about exercising people with heart failure or other cardiovascular conditions. Always happy to take questions and provide some general to people. So please don't hesitate to reach out if I can help.
Yeah, and please stay and ask any questions. I've got a quick one. What would you use instead of the term heart failure? What's your thoughts?
If you want to use a more clinical term, you could talk about left ventricular dysfunction.
Yes, dysfunction.
It probably doesn't. Dysfunction, I feel, is a less threatening term than failure.
Yes.
Sometimes when I'm just talking to people about their heart condition, I'll talk about their impaired heart function, or their reduced heart function, or the fact that their heart's not pumping as strongly as it should. Using that sort of language rather than saying you've got heart failure, your heart's failing. I think you can give the same message about the fact that the heart's not working as well as it should without using the term failure.
Absolutely. And I find we spend a lot of time where people have been, the doctor said I had heart failure, and what does it mean, and so you do get an opportunity to to tell them about the term without using the words. But really, yes, be good if we could, for patients, call it something else.
I think that's the benefit that that we have as health professionals. If you are working with with people at the coalface, you can just explain what the term means. That it doesn't mean the heart's completely failed. It's that it's a term that really describes when the heart's not pumping as well as it should, and that does have impacts on how a person feels. But we do need to change the narrative a little bit, I think, to be a little bit more positive and forward facing in a positive way rather than all doom and gloom, because it's not all doom and gloom for many people with heart failure.
And there's new drugs now where the trajectory was that it was a palliative condition, but nowadays we have so many other options, and especially with heart failure, not so much with the preserved ejection fraction, but we do have many new drugs around which really don't have that same prognosis that we used to think of.
And one of the benefits of having worked in the area for such a long time and with a unit like the Advanced Heart Failure Service is that people come in for annual checks, and often I'll bump into someone in the waiting room who came to our gym 20 years ago and is still
Yes.
doing relatively well, just getting on with their life. They've still
Yes.
got a heart that doesn't work as well as it should, but you know, they've had a really good life and it's been reasonably well controlled, their heart condition. So we see that all the time, these people who have had long and productive lives despite being diagnosed with a failing heart, 15 or 20 years ago.
Yeah, and it is that quality of life. Another part that I really resonated with me is people doing things for others. It's so true what you said about losing your sense of self-worth. I've had a couple of patients recently who actually were becoming quite depressed because they were, they'd been a strong farmer and suddenly everybody was doing everything for them, and they just kind of turn their face to the wall. And you've got to give people back that sense of self-worth.
Yes, definitely.
So great point, Andrew. Any questions from the room? I'd just like to thank everyone for attending and thank everyone who contributed to the questions, etc. But thank you, Andrew, as always, a fantastic presentation. Thanks a lot, and thanks, Taylor.
Okay, thanks for having me, Helen, and thanks for listening, everyone.